Well, thank you so much to all of you for hanging in to the last talk of the day. I also want to thank the organizers for having me here today. I'm not sure if it was made clear in the introduction, but I'm a pain psychologist. I don't have medical training, and I always like to say that, partially because there's some misinformation on the internet, but also because it'll make clear sort of the trajectory of my path and my interests and what I'll be focusing on in this talk. So here's my disclosures in terms of my NIH funding and some minor consulting. So pain is a huge problem, not just in the United States, but worldwide. Most of you in this room have probably experienced chronic pain at some point already, but if you haven't, you will in your lifetime if you live long enough. If you don't have chronic pain now, you probably know somebody who does. So approximately 1 in 3 individuals is living with ongoing pain. And this is true not just in the United States, but really worldwide. So no matter which country you're living in, the prevalence of pain and even the incidence of pain is similar. So this is striking, and really only in recent years has this come into our awareness of not only the incidence, prevalence of pain, but also how impactful it is. This 2011 report from the Institute of Medicine really detailed some of the impacts of pain. In terms of its economic burden, we see that up to $635 billion are attributed to costs for pain care and also lost productivity from work. So it's a major impact on our national economy, but also we want to look at human suffering. And so this has major impacts there, not just on the person with pain, but also the family, individuals, and their families. So I like to set the stage just by going into a little bit of background in terms of the relationship between psychological disorders and the occurrence of pain. And we see that there's a relationship between anxiety, depression, post-traumatic stress disorder, and then the acquisition of a painful condition. So we see it moving in that one particular direction, this co-occurrence. But in fact, it works both ways. And so we see that once pain is acquired, people are more likely to then develop a de novo episode of depression or anxiety disorder or post-traumatic stress disorder. So there's this tremendous overlap between pain and these psychological disorders. And in fact, we know that women are also more likely to experience these psychological disorders than men. And so while we could say that there's this bidirectional relationship between psychological disorders, psychological factors, and pain, I'm not sure why those aren't aligning right. In fact, it's more than just a bidirectional relationship. There are these shared mechanisms between psychological experience disorder and also the occurrence of pain. And some of those are related to the immune system and immune-to-brain communication that deeply impacts the modulation of pain. And as I think you've been hearing throughout the day, there's also hormonal impacts that profoundly influence both psychology and also sensory experience. And so we can kind of set the stage for understanding that these shared mechanisms may be more impactful and consequential for women. So indeed, we see that there is a striking female preponderance for the experience of pain. And while there's really equivalence in very young childhood, we see that these sex differences emerge around puberty, and that girls around puberty will report greater pain intensity. And not only do they experience greater pain intensity, but we can also start to see differences in how adolescents, girls and boys at that age begin coping differently with pain, such that girls are more likely to be sort of ruminative or internally focused, more likely to engage with catastrophizing, maladaptive coping, whereas boys are more likely to engage distraction. We see that in adulthood that women are much more likely to have a chronic pain condition. And so, for instance, like with migraine, it may be 3 to 4 times more likely to occur in women than in men, with some studies showing that up to tenfold likelihood for women to acquire certain chronic pain conditions such as fibromyalgia. Typically, if there's a strong immune component to the underlying disease, then women are going to be more likely to experience that, such as rheumatoid arthritis, for instance. And I just highlighted this one study as an example. This was a population study conducted in Swedish older adults, and this was approximately 2,000 individuals. And what they showed is a slightly greater than 3-fold likelihood for older women to report having ongoing pain than men. And this is just really what we see across the board. I'm a psychologist in the Stanford Pain Management Center. At least on Fridays I am. The other days of the week I'm in the lab. But what we see in the pain clinic is that about 2/3 of our patients are women. And when you really look at the literature and the studies on pain, the clinical studies, what you find is approximately that, 2/3 to 3/4 of the samples, sometimes even more than that, will be female. So sometimes we joke that we have the women's pain clinic. It's not that men don't have pain, but it's just of greater magnitude and consequence in women is what we see. So these sex differences in adulthood, across the board, we see greater pain sensitivity in women. And this is true in laboratory and clinical experience. So we can bring men and women into the lab. I'm in the Stanford Neuroscience and Pain Lab, and we bring individuals in and we put them through standardized pain testing experiments. So we evoke pain, we expose them to a standardized stimulus, but women will report greater pain intensity to the same stimulus compared to men. Again, this is true in healthy women and also women who have chronic pain. There's evidence to suggest that women have poorer pain inhibition, suggesting that that their descending pain modulation is not as strong as it is in men at baseline. So it's tempting to think about pain as being a purely sensory experience because that's where it really shows up in our bodies, right? But the truth is that it's not. This is the definition of pain from the International Association for the Study of Pain. And here's the definition. This is a stricated version of it. But pain is both a noxious sensory and emotional experience. So I highlight this because psychology is actually built into the definition of pain. It's integral to pain. So I like to talk about pain as really being a psychosensory experience. And when it's framed that way, I think it helps us understand why pain is of greater consequence in women and why there's greater prevalence of pain in women. So, in fact, pain is a product of the nervous system. And it's very complex. There's multiple psychosocial factors that are fluid and interplay with both the experience of pain and also the trajectory of pain. And just as an example, our expectations, our beliefs and our expectations are incredibly powerful. If we believe that something is going to help us, is going to help our pain, we're much more likely to derive benefit from that treatment or to experience analgesia during that circumstance. This is, the basic underpinnings of what we call the placebo response. And on the flip side, the nocebo response, if we're fearful of pain, if we interpret pain negatively, or if we believe that a treatment will not help us, it serves to actually amplify our pain. So what I'd like to highlight is that pain is not a static experience. It's not something that happens to us, despite most patients and people believing that. But in fact, we're continually participating with our pain based on our responses, our reactions, our beliefs, and our expectations. patients. And this really sets the stage for pain psychology and what we do as psychologists in the pain clinic. So I like to talk about pain as being our harm alarm, and it's designed to get our attention, to motivate us to escape whatever threat is afoot, whatever is potentially harming us, could cause damage. It is our danger signal. And this harm alarm simply rings louder in some individuals than in others. And I would submit that it rings louder in women than in men. And we could talk about the evolutionary benefit of that. And I think it's kind of easy to derive some hypotheses about why that might be the case. But while we all experience pain and this harm alarm rings and we're motivated to escape it, we're born with the inherent motivation to escape pain, we're not born with the inherent understanding about how to modulate pain or how to modulate the distress that it causes us. And so a primary example of the distress of pain is pain catastrophizing. And this is really my area of empirical focus and also clinical focus. So pain catastrophizing is a negative cognitive and emotional cascade. It's a response to actual or anticipated pain. And so that's a really important point that I just said. It's actual pain or anticipated pain. So you don't even need to be experiencing pain this very moment to catastrophize. It's comprised of three components: magnification, rumination, and feelings of helplessness. And really, in the literature, that middle subscale, rumination, turns out to be the big player, the big driver in terms of why catastrophizing is so impactful. So these are sample items from the pain catastrophizing scale, which is 13 items, which simply assesses how you tend to think and feel in the context of a painful stimulus. That could be going to the dentist, it could be after an injury. If you don't have pain on an ongoing basis, you're just directed to consider, reflect about times in your life when you have experienced pain. So all of us in this room, regardless of whether we have pain, can complete the pain catastrophizing scale. Here it is. And you're rating the frequency at which you experience these thoughts or emotions in the context of pain on a 0 to 4 scale, with 0 being never and 4 being all the time. And you basically give yourself a number for each item and you sum that score. And that total score on the pain catastrophizing scale turns out to be an incredibly powerful prognostic indicator for both the trajectory of pain and also pain outcomes in general, how patients and individuals will respond to various pain treatments. So pain catastrophizing is associated with an array of negative impacts and outcomes. You can see some of them listed here. This here was a systematic review that essentially distilled down. There were a total of about 1,500 patients included in the various studies in which they reviewed the impacts of pain catastrophizing and showed that it's associated with greater pain intensity, disability, and also poorer recovery from pain. Interestingly, those 13 questions, your sum score will predict whether or not you go on to develop chronic pain. And this is true in people who have an injury, so they have acute pain. One of the big questions in medicine is, well, how do we prevent chronic pain? Can we catch people earlier? Can we treat it better sooner? And in fact, it turns out that catastrophizing is a very important therapeutic target because it does predict who goes on to develop chronic pain following an injury or even among healthy individuals. And we find that it actually mediates how well other treatments will work. And this is shown in multidisciplinary pain clinic settings. So what are some of the mechanisms of catastrophizing? The truth is that there are many, they are varied, and I don't have enough time to go into all of them, but what I wanted to distill out was some of the key findings that I thought would be most interesting to you, this particular audience. I am not a neuroimaging scientist, but I have the luxury of getting to work with people in that space in team science. What we know about pain catastrophizing is that we can take people and put them into the scanner, and we can see that when people catastrophize, this first study is done in healthy individuals, we can see altered patterns in the brain, that essentially when an individual catastrophizes, it lights up the regions of the brain that are associated with pain. And so we're essentially, with our attention and with focus, we can actually amplify pain processing, quantify that, and describe it. More interesting than that, to me, is that we can look at catastrophizers versus non-catastrophizers. And what we show is that this repeated pattern of catastrophizing actually changes the brain at rest. So the default mode network is different in catastrophizers versus non-catastrophizers, suggesting that there's lasting changes that are occurring. And we believe that this sets people up for prolonged symptoms and enduring pain. So this was a study conducted by Dr. Etkin here at Stanford, and this was an interesting study comparing healthy controls and people with chronic low back pain. And essentially what was found was that the rumination subscale of catastrophizing was predictive in showing an overcoupling between the amygdala and the central executive network, again suggesting that these psychological patterns lead to not only greater distress, but also have greater impacts in individuals, and we can establish this neurally. This study was another study conducted in individuals with migraine. So they looked at the impact of migraine over time, and they also were interested in looking at the impact of catastrophizing in migraineurs, comparing healthy individuals to migraineurs. And so what they show is that they're able to image neural impacts in individuals with migraine, and that is dependent on the duration of the disease. So people who have migraine longer have greater impacts. But that more than that there's this overlay of an impact of catastrophizing that really amplifies the negative effects in people with chronic pain. And I just want to underscore, again, these studies when I'm talking about the one before, Dr. Etkin's study, this study by David Seminowitz's lab, when you drill down and see what the proportion of women is in the samples, it's about 75% of the patients, not necessarily the controls, but the patients are women. So I like to describe this as being a metaphor for catastrophizing and for pain. So imagine that this is your pain, and when we catastrophize, it amplifies pain in the nervous system. So it's like pouring gasoline on a fire. It not only amplifies the experience of pain in the moment, but actually has lasting changes on the brain. Now, a primary question that people often ask is catastrophizing more common in women? And the truth is the data are pretty mixed. It's kind of surprising to me because I would think that it would be much more common in women. But in fact, some studies say yes and some studies say no, and it's not quite so clear. But again, what I argue is that the impacts of catastrophizing are much greater in women. So we were interested in this particular study. This was conducted on patients in the Stanford Pain Management Center, and we looked at data for about 1,800 patients with chronic pain. And we were interested in understanding what predicts who gets opioids versus somebody who doesn't get opioid medication. And about 60% of people who come to the pain clinic are already on opioids opioid medication. So can we characterize and distinguish who's likely to be on opioids versus not? And we wanted to look at pain intensity and also pain catastrophizing as variables of interest. So these are heat maps that are displaying some of the data. Each individual point is a person. This display here is a probability of being prescribed an opioid, with red being higher probability and green being lower probability of being prescribed an opioid. And what we found was interesting, was that men were more likely to be prescribed an opioid if they had very, very high pain intensity, whereas women were more likely to be prescribed an opioid based on catastrophizing at higher levels and also at lower levels. This was actually the most interesting point to me, which shows across the continuum of, we separated out by quartile, but the pain catastrophizing scale is 0 to 52. So separating that out by quartile, the pain catastrophizing score on the x-axis, what you'll see is that there's sort of this inflection point right around maybe 10 or 11 or so, where women are more likely to be prescribed an opioid than are men. This suggests that catastrophizing has some sort of predictive value in women at much lower levels than we normally tend to think about. When people come to the pain clinic and we give everyone a pain catastrophizing score, often we think about catastrophizing being sort of clinical or actionable around a score of 30 or so. But there's a convergence of newer data suggesting that lower scores, when we take a look at those lower scores and really characterize what's happening at those lower scores, that they actually do have predictive value. Most of that's in the surgical realm, which I'll talk about in a moment, but I wanted to share this point with you here. So how do we treat catastrophizing? Typically with cognitive behavioral therapy, this is done with a psychologist, often a pain specialist. Typically, people can be treated individually or in groups. In the pain clinic, we tend to treat people in groups because we're able to do high volume. And there are so many people with pain, so it's an efficient way to treat a lot of people. But they have to come for 8 sessions, 2 hours at a time. So it's 16 hours, which confers a substantial burden to people who have chronic pain, having to come back for multiple visits, co-pays, et cetera. But CBT is very effective for treating chronic pain and treating the impacts of chronic pain, and that's why people do it. There's about 25 years of research behind CBT showing its efficacy. And a question I always get asked is, okay, so CBT works, but you talked about those changes in the brain. Does it restore some of these deficits that are shown in some of the neuroimaging data? And in fact, there was a really elegant study done in 2013. This is David Semenowitz's lab, where he took individuals before CBT, imaged their brain. They went through 11 weeks of CBT, and then they got a post-treatment scan. And what the researchers showed was that after those 11 weeks of CBT, they were able to evidence volumetric increases in the regions of the brain associated with pain control. So they literally grew those regions of the brain, strengthened those regions of the brain. That was measurable, it was significant. And the interesting point was that it was entirely predicated on how much they improved, how much they reduced their catastrophizing tendencies. So yet again, showing that the big player over and over again are these thought patterns, day-to-day thought patterns and responses that we have to our pain, not necessarily clinical depression or some of these other factors, which are certainly important, but not necessarily relevant to every single person. So there was some recent research that was interesting to me because these researchers showed that in as little as 80 minutes, you could take naive individuals who are naive to meditation, give them about 80 minutes of training in meditative techniques and be able to show that with as little as 80 minutes, they were able to modify their experience of pain. They were able to reduce the intensity of pain that they experienced following a pain stimulus. They were able to significantly reduce the pain bothersomeness. They received the same stimulus pre-treatment and post-treatment, but by learning and using these meditative skills, they were able to substantially reduce intensity and bothersomeness. So I thought, this is amazing. 80 minutes, what are we doing here? It's 16 hours of CBT and all of these things. Now, this was a healthy sample, though. So our question was, could this work in individuals with chronic pain? This is the idea, right? So what myself and colleagues developed was a 2-hour compressed pain psychology class. And the goal of this class is to educate individuals about what catastrophizing is, how they can identify it, what they can do about it. So it's essentially a compressed pain psychology treatment. And we were interested in understanding if this would help them. We report data for 57 participants who went through the class, and greater than 80% of our sample is female, and it just happened to be that way. We didn't really, we weren't targeting women. So some key underpinnings of what people learn, the takeaways. I mentioned this earlier, that pain is not a passive process, that we are not a victim of pain. It doesn't just happen to us, that we are constantly participating with our pain. And so there are tremendous opportunities to learn how to modulate our experience of pain. Not that any of us asked for pain, and so, certainly it's not our fault that we have pain. But once we have pain, there's so much we can do to either dial that pain down, or unwittingly, we could be turning up the volume of our pain. And so I always say, nobody wants more pain. But if we don't learn that those critical information and those critical skills, that's what's happening behind the scenes. And I think that this is what's happening behind the scenes for a lot of women, because again, physiology being primed to experience pain and to have heightened responses to pain, but we don't necessarily know what to do about it. So something like this type of treatment could be more applicable, more relevant to women. So catastrophizing is critically important, not just for our own experience, but also in terms of setting us up to either have a better response to medical treatments or not. So we're not just participating with our pain, we're also participating with our medical care. And if catastrophizing is on board, we can actually undermine the efficacy of opioid medication, of our surgical response, of all of these different treatments that physicians may try. This is a critical concept for patients to understand. So we did the pilot class and got some great results for that. We showed reductions in catastrophizing from a single 2-hour class, which was exciting to us because we weren't sure whether we could actually, we know that catastrophizing is plastic, but the common thinking was that it took these 8 weeks to get there, and we showed that we could get there pretty rapidly, and that we evidenced these clinically significant changes, reductions in catastrophizing, large effect sizes. We're able to turn this around pretty quickly into an R01 grant, which we are now just launching our 3-arm clinical trial, comparing this single session to 8-week traditional 8-week CBT, comparing it to health education control. And the goal is not just to see if we can get durability of effects for this single session class, but we're really trying to understand mechanistically, how does catastrophizing change? And I'll be excited to look at the sex differences in that study too, but we're literally just starting it this month. So we talked about chronic pain. One of my passions is actually thinking about preventing chronic pain. I sort of touched on this earlier. And, surgery is a big cause of chronic pain, believe it or not. About 10% of people who have surgery will go on to have chronic post-surgical pain. For some surgeries, it's much higher. So, if, total knee replacement, you can see post-surgical chronic pain rates as high as 33% or so. So, surgeries are very common, about 230 million a year, and it's basically a controlled injury. So what do we know about how catastrophizing impacts surgical outcomes? Well, you could probably guess this based on what I've said. How many minutes do I have? Are we at time? Okay, pretty close. So I'll go through this very quickly. The short story is that catastrophizing has been shown to be the most powerful predictor for post-surgical outcomes in these studies. You might think it's like the surgeon or the disease characteristics, but in fact, it's some of the psychological factors. And so we were interested in seeing, could we apply this class, these concepts? Could we teach people pre-surgically about catastrophizing and how to stop it as a pathway to help people have a better surgical response? Now, if you think about a pre-surgical study, people can't even come in for that often, so we developed an internet-based treatment called My Surgical Success. So patients, it's all online, automated, basically free. They can go online, watch a 90-minute educational video. They can download a personalized plan and complete it, download the audio, and we can track them over time. So this just shows the randomized controlled trial flow chart that we just finished. And what you'll see is we're randomizing people to health education control and to this online automated treatment. And then we're tracking patients to see how they do after surgery. We are particularly interested in time to pain cessation and time to opioid cessation after surgery, as well as functional measures long term. We're testing this in women who are undergoing surgery for breast cancer. So I think, I wish I could present data to you, results for that, but we don't have them yet. But we are hoping that these types of brief treatments will help not only target pain, but also the psychological factors of pain that are so integrated and predictive of outcomes, help people focus less on medications and more on acquiring these self-regulatory skills that are so important. So if you ask me who needs psychological treatment, I would say everyone does, but probably even more consequential for women. So with that, I will just say thank you, and hopefully I didn't go over too much. Thanks.